Okay, thank you very much. I'm going to make a presentation on a study that formed part of 5 other studies that were conducted in Kenya last year that looked at, among other issues, the accuracy of HIV self-testing, linkage to care, packaging and messaging of HIV self-test kits, as well as the distribution of HIV self-test kits that I'm going to talk about. As my colleagues have talked, as presented by my colleagues, it's evident that there has been marked increase in HIV testing and counseling levels in many settings in Africa. For instance, in Kenya, there has been an increase of uptake of HIV testing from 34% in 2007 to almost 80% according to the recent Kenya AIDS Indicator Survey that was done in 2012. Despite this, only 47% of HIV positive individuals know their status, and this is partly attributed to confidentiality and stigma concerns that likely remain a barrier to facility-based HIV testing and counseling. In order to bridge these gaps, it's important to have new approaches, such as HIV self-testing, that can reach the other half of 50% individuals who do not yet know their HIV status. Rapid diagnostic tests, such as HIV self-tests, provide an opportunity to overcome confidentiality and convenience barriers. In Kenya, the use of HIV oral self-test kits is already being considered by the government, and it forms part of the HTC guidelines. However, it's not been operationalized yet because of lack of adequate understanding of HIV self-testing, as well as how to distribute them. So the overall objective of the study that we did in Kenya was to generate evidence to inform the design and evaluation of programs using HIV oral self-test kits. And the specific objectives were to examine the possible outlets and all networks for distribution of HIV oral self-tests in Kenya, to explore how the distribution of the self-tests through various channels can be organized to better meet the needs of potential users. And the last objective was to examine the possible linkages to counseling and care for users of HIV oral self-tests given the choice of the distribution outlet. The study was exploratory, and it involved both quantitative and qualitative data collection methods, and it had 3 components that involved the demonstration of the use of the self-test kits. So before we initiated each of the survey activities, we actually showed study participants how the HIV oral self-test looks like before we started asking them questions. So the study components involved a community survey. We also had service provider interviews and key informant interviews. Depending on the activity that we did for data collection, we either used random selection or purposive sampling of participants. The study was conducted last year in October, and we interviewed 1,436 individuals aged 18 to 64. This included 969 women and 467 men in 4 counties across Kenya. The counties represent the western part of Kenya, the central part of Kenya, and the coastal region of Kenya. We collected information on background characteristics, potential use of the kits, preferred distribution outlets, and linkage to counseling and care. Similarly, the service provider interviews was done at just the same time, and we interviewed 317 service providers aged 20 and 65 years. We interviewed both public and private providers. We also interviewed providers who man voluntary counseling and testing centers, as well as individuals who work in private pharmacies, as well as community health workers, traditional birth attendants, and shop and supermarket owners. This we did in 5 counties, including Nairobi. And we asked questions about background characteristics, services provided at the outlet, potential use of HIV oral self-test kits by clients, and possible channels for distributing the kits. Again, we also did qualitative interviews, key informant interviews with 27 key informants drawn from opinion leaders, representatives of community-based organizations, Ministry of Health officials, including the DASCOs, PASCOs, and NASCOP officials, as well as Kenya Medical Supplies Agency representatives, social marketing and outreach agencies, and representatives of special groups such as female sex workers, persons who inject drugs, and persons with disabilities. The key informant interviews were also done in 5 counties in Kenya, and we asked about the potential use of the kits in the community, readiness to give information and distribute the kits, and how the distribution channels can be organized to meet the client's needs. Our results generally show that a vast majority of participants had previously tested for HIV. As you can see, 93% of survey women and 79% of men indicated that they had previously tested for HIV. And among those who had tested, a large number had also tested in a public health facility. With regards to potential use of HIV oral self-test kits, majority of survey respondents indicated that they would use the kits. As you can see, 94% of men and women indicated that they would use the kits if they availed to them. Similarly, 91% of service providers also reported that their clients would use the kits if they're given. The narratives that we analyzed from the key informant interviews also showed that many people would use the kits. If I can just read one quotation, people want to know their status, but the problem with the current HTC setup is that for me to know my status, someone has to know my status. So these are some of the findings that we got from the key informant interviews. In terms of the distribution channels, 83% of survey respondents mentioned that public health facility was either the main or alternative source of HIV oral self-test kits. There was a preference for these kits to be distributed within the public sector. This was closely followed by private pharmacies, local administration, private health facilities, and local shops and supermarkets. This just illustrates the proportion of distribution of channels as stated by the survey participants. We also went ahead and asked the advantages of the distribution channels mentioned by the participants. We asked them what they saw as the advantages of each of the distribution channels that they mentioned. And for the public sector, the survey respondents, service providers, and key informants mentioned that the advantage of distributing these kits through the public sector was that the public health facilities are widely distributed, and this would allow for ease of access to get the kits. At the same time, there are also issues of, there are also concerns about the cost, and most individuals thought that the cost of services in public health facilities would be much better compared to the private facilities. The other issue was about quality of services and availability and interactions with clients. On the other hand, we also asked about the limitations of distributing these kits through the public health sector. And some of the concerns that were raised included red tape and bureaucracy, lack of privacy and confidentiality, lack of training, and long waiting time. We also went ahead and asked the providers whether they were ready to provide information and distribute the kits. And as you can see, a large majority of providers indicated that they would give information and also distribute the kits. In ranking order, the reasons given for readiness to provide information included adequate human resources, adequate infrastructure, large clientele, and appropriate training. And the reasons given for readiness to distribute the kits included the providers having large clientele, the distributions does not require huge amounts of resources, and adequate human resources. Readiness to give information and distribute the kits was also evident from the key informants' narratives, as you can see. We also went ahead to ask how the provision of the kits can be well supported. And again, we ranked the information that we got from the participants, and it emerged that some of the things that were seen as important included training or updates on self-test, adequate IEC materials, community sensitization, additional financial resources, and additional human resources. Whereas support needed to distribute the kits included training and updates on self-test, reliable supplies, having reliable supplies, community sensitization, and having adequate IEC materials and additional information and financial resources. We also explored issues of linkage to counseling and care, and more than 70% of women and men indicated that they would seek counseling services both before and after performing the HIV self-test. Similarly, 62% and 71% of providers also felt that their clients would seek counseling services before and after performing the HIV self-test. However, the key informants that we talked to had mixed views with regards to seeking counseling before and after performing an HIV self-test. If I can just read the quotation quickly, one informant noted that it will depend if I get negative. I will not need, there are those who will need it if they are positive. But also the other dimension was that if I take this kit 2 or 3 times in my house and find that I'm positive, naturally I will want to go to the hospital. We also explored the sources of counseling services where participants would like to get these counseling services. And what emerged was that public health facilities were the most preferred sources of counseling services, both before and after testing among survey women and men. As you can see, nearly 3/4 of respondents indicated that they would seek counseling services in public health facilities, both before and after testing. To summarize, the findings of this study shows that there was a near universal acceptance of the use of HIV oral self-tests among survey respondents. This information was also backed up by data that we collected from service providers and key informants that also confirmed that the self-test kits would be acceptable in the community. The 5 other studies that were also conducted in Kenya also showed high acceptability levels of HIV oral self-test kits. Again, public health facilities seems to be the most preferred choice for distributing the kits and also for getting counseling services. However, in order to have efficient organization and distribution of the kits, most service providers that we talked to indicated that they require training or updates on self-tests, adequate IEC materials, community sensitization, and reliable supplies of the kits. That is the end of my presentation, but before I finish, I would like to thank the International Initiative for Impact Evaluation 3IE for funding the study, and also Ministry of Health in Kenya for supporting the study, and also the stakeholders that participated in the study. And most of all, I would really like to thank respondents who shared the information with us. Thank you very much.